Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week sessions. So we had our first trial class back in September, I think about a week ago, right? 2 weeks ago. So I hope that you learned a little bit about the mental state examination, which is the basic of psychiatry preparation. So we talked about how to take a proper history from a psychiatric patient. We talked about the MSc presentation to the examiner. Now you must, if you are already preparing for AMC Clinical, you already know that MSc is a very, very important topic for your exam. That's why we give enough time so that you understand each and every step of this. So, because many times what we see that if you know MSc presentation, most of the time you get it right in the exam and you can easily pass this case in the exam. And from psychiatry, ideally one or two cases come in the exam. So if you already get one MSc case and then there will be another history case, so it becomes very easy to pass the psychiatry cases. But in other way, many times students fail the two cases because psychiatry is hard and also the examiner and the exam actually ask a little bit more better approach for psychiatric cases. So if you know how to take a proper history, it becomes easy to pass these stations. Okay, so tonight we are going to focus on MSc role play. So how we actually take the classes, that's what you are going to go through in the next 2-week session. And interestingly, our 5 months AMC clinical course is starting from today as well, which means that there are already, I can see there is more than 50 students who are already enrolled into the course. They are already taking the course. They have enrolled into the course. You are also getting the same classes as they are. Why we do this is because that you need to actually understand how we take our sessions to start preparing with us. This is a big step because we are taking 5 months to make you well prepared for the exam, and you need to know about the course before you can enroll here. And that's why we allow you to go for at least 2 weeks with us, understand how we take our session, and then if you like it, then come and join us. And if you join us, then it is our responsibility to make sure you are well prepared before you go for exam. So we take that responsibility, but still, it is your part as well that you have to do your hard work. You have to be confident to go for the exam. There is no one or better way rather than that. You have to do your part, and we will do our part as well. And together, hopefully, you should be able to reach your dream. So let's not prolong it. Let's start our session today. So today we are going to do role play session. What we normally do in classes is that there are some theory classes and there are some question solved classes or role play classes. So you'll be getting a role play class very soon with Dr. Cynthia, who is also one of our very well-known doctor who takes those role play sessions with you. So that will be in 2 days time. That will be on 9th October. So today is 7th October, so Saturday. So Monday, you will get that random role play session with her, and she's going to go through just a random role play. There is no syllabus for it. Initially, it becomes a little bit tricky because you don't know anything about the cages. But as you go with the classes, as you become more prepared, these classes will be much more interactive and much more important for your exam. So that will be Dr. Cynthia will be taking 2 of those sessions with you in this 2-week session. And obviously, I will be going with your theory classes. So how we divide the classes is first we take a theory class like we have done in the trial class on 23rd September. That was psychiatry MSc theory class. Now you know how to take a MSc presentation, how to take a psychiatric history. So after that, we do a role play on that topic so that you understand how the cases come in the exam and how to do a proper role play to make sure you are well prepared for your exam. And then there are some random role play sessions which will be taken by Dr. Cynthia with you. Okay, so let's start the role play sessions. Now, in a role play session, what we ask you to do is that if you are a beginner, don't worry about it. Just come and do the role play so that you can learn. Okay, and we will give you feedback to see that what you can do to improve yourself. But if you don't know anything about MSc presentation or psychiatry history, then it might be a good idea that first do the class that we have taken and then do the role play with us. Okay, so who wants to go for the first role play? Dr. Priyanka? Okay, so let's do with Dr. Priyanka and then Dr. Jahara and Afsan. So we'll go in that range. So Dr. Priyanka, if you can unmute yourself.
Yes, doctor. Can you hear me?
Yes, I can hear you. Thank you. Okay, let me give you the case. Just let me stop sharing this one and I will give you the case. Okay, so what we'll be doing is that we'll give you 1 minute time for outside preparation and then 7 minutes 30 seconds for the case. Normally, you'll be getting 2 minutes in the outside to read and prepare for the case and 8 minutes inside. But when you prepare with us or with your study partner, you can make it 1 minute outside and 7 minutes 30 seconds inside. Okay.
Dr. Harshan, what's the name of the nurse?
I will give it to you before we start.
Okay.
All right. So this is your patient. Your patient's name is Sam. You can start.
Okay. Hi, Sam. I'm Dr. Priyanka. I'm one of the GPs working here. It's very nice to meet you. I understand that you came with your wife. Can you tell me in your own words why you are brought here? Okay, Sam, I understand it's really difficult, but let me reassure you that whatever we talk today will be between you and me, unless it's harmful to you or others. You just can talk to me as a friend. Can you tell me what happened and why you're here?
Yeah. So I just don't want to leave.
Oh, I'm sorry to hear that from you. But Sam, we are here to help you. You can please elaborate on what you're feeling. Can you tell me how your mood has been these days?
Yes. I don't know. I just don't feel myself anymore.
Okay, Sam, I'm really sorry to hear that again. Okay. Are you feeling very low or
Yeah.
do you feel that way?
Yeah, I feel low.
Okay, that's fine. Can you tell me how has your appetite been? Are you able to eat well or has it gone down?
I don't want to eat. Just want to end this.
Sorry to hear that again, Sam. Please don't lose hope. We're here to help you. Can you tell me how is your sleep been these days?
Honestly,
Sorry,
can't sleep
can't sleep. Okay. How long has all these been happening, Sam?
for 3 weeks.
Okay. Okay. All right. So I understand that you have been you just came here with your wife as you were trying to hang in a row. I'm so sorry to hear that, Sam. But can you tell me what happened? Why did you do that?
Yeah, I I killed that patient because I know that if I was more careful, then that
Yeah.
patient would live. But
Okay.
it's just for my stupid mistake. The patient is dead now.
Okay. I'm really sorry that you're feeling this way, but it's so um did you think that you want to end your life by doing this?
Yeah, I don't
Okay.
deserve to live anymore.
Okay. So you don't think your life is worth living now?
No,
Okay. So sorry again. Okay. And have you any thoughts of harming anyone else?
no, I just want to end my life. That's it.
Okay. 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 So how are you guilty of anything at the moment?
Yes, I killed that patient. So
Okay.
I am guilty. I know it. Even though the nurse committee says that it's not my fault, but
Okay.
I know that this is my fault, and
Oh, I'm
they're just
sorry.
trying to save me. But
Okay.
yeah, I know.
All right, Sam, please don't worry. I will help you with that. So how has your concentration and energy levels been all these 3 weeks?
It's all over the place.
All over the place. All right. Okay. And have you lost an interest in things that you used to do before?
Yeah, I don't want to do anything. I just want to sit and in this
I'm so
miserable life.
sorry, Sam. Okay, I'm sorry, really sorry with that. Okay, so I'm going to ask you some weird questions. Please bear with me. It's just part of my, my questions to you. So, are you hearing or seeing or feeling things that other people don't?
I can hear some of the nurses' voice. They're saying
Okay.
I'm the murderer.
Okay. Are they saying any other thing other than you're a murderer?
No, they just say I'm the murderer of patient and I don't deserve to live.
Okay. And are you able to see them as well?
No,
Okay. Do you hear these voices when they're around you or when they're not there?
sometimes they are not even there, but I don't know. It's just a strange feeling. I
Okay,
can
I'm
hear them.
sorry. Okay. And do you think that people around you are talking about this, that you killed the patient all the time?
No, it's just the nurses.
Okay. Do you think people are spying on you or trying to kill you?
No, I wish if they can do it, then it will be easier for me.
Oh, okay. Okay. Do you think that you are having some superpowers or anything like that?
No,
Okay. And you said you're having a guilty feeling about this, right?
it's not a feeling. I know I am guilty.
You are guilty. Okay. All right. And do you know why you're here today with your wife to see me?
No, I think my wife is just concerned about this.
Okay. Okay. So do you think you need some medical help now?
No, no one can help. It's not possible to help me anymore.
Okay. Can you tell me if this is a probability question? If this place catches fire in the room, what will you do?
I'll just stay here.
Okay. All right. And I'm so sorry to hear that, Sam. Do you know what time and what day and who you're talking with?
Yeah, I know. I think it's Saturday.
Sorry, Sam?
I think it's Saturday.
Okay. And who you're talking with?
The doctor.
Doctor. Okay. All right. So who do you live with at the moment?
Time up. Thank you, doctor.
Oh my God.
Okay. Yeah, I know, right? So
It is-
you did good, Dr. Priyanka. I'm really happy with your approach. You are already doing really good. What I
Okay.
want you to do is to make it a little bit faster, because as you
Okay.
can see that sometimes the time can run out even if you are not aware.
Yes,
It will
doctor.
just run out like this. Okay,
Yes.
so
Okay.
it comes in your head. If you do a lot of role play with your partners, then you will know when the time is running out. So
Yes.
7 minute 30 second, it is still you are taking the history, right? So it means that
Yeah.
you still will take history for 8 minutes. So
Yeah.
what I would say that there are few things what you can do in these cases. First thing is, when you perform this task, first
Yeah.
look at the task. Task is perform mental status examination and and presentation to the examiner. So you
Mm.
only need informations related to aseptic J3R, right?
Oh, yeah.
Yeah. So you don't need to diagnose this patient as major depressive disorder. So you don't need to ask questions related to depression, like concentration, attention. Those are
Okay.
not needed. Even though we know this patient most likely is a depressed patient, but it's not needed for this case. If we
Okay.
want to cover each and everything, then likely chance we will not be able to finish it in time in exam. So, because as long as you can perform the task, the marking is there and you can pass this station. And that's
Okay.
what we are looking for. You don't need to
Okay.
take a history for 7 minutes and getting a 6 in history, but 0 in MSc presentation. That will
Okay.
end up fail in the exam. Better
Okay.
is to get a 4 in history and at least 4 in MSc presentation, and globally you can pass this exam. Okay, so
Yes. Yes.
that will be the target. What we normally think in these scenarios, we think that no, let's take a very good mark in history and then maybe just pass this last task. If you
Mm.
think in that way, then the problem happens. So think that I will just get pass mark in both and I will pass this station, because as long as you pass this station, that's
Mm.
all that we need, right?
Yeah. Okay.
Okay, so that means that you don't need to ask everything in the history. Make it
Okay.
short, make it related to your aseptic J3R presentation, which means you need mood that will come into the emotion. You need that hallucination part. You
Hallucination.
need the delusion part. Yeah. So insight,
Yeah.
cognition, judgment, those you asked, and then the risk, rapport, reliability that will be completed in your history anyway. So ask just that question and
Yeah.
then finish the MHC presentation. If you have some time left, then you can go back and you can ask some history if you want. Okay.
Okay. Doctor, do we ask about heads and organic process in MS?
So it depends on how fast you are. It's
Okay.
not must that you have to take the heads, but psychiatric history, usually we should just ask very quickly, how is your home situation and how is your work situation? That's it. Or even
No.
you can just ask, how is your home and work situation? That will cover just within a second, you can finish this. And then do you smoke or drink alcohol or any other recreational drugs? So that will be your fastest way to finish the heads and SADMA if you're running out of time.
Okay.
Okay.
Okay. Thank you, Dr. Ashok.
Okay. Now tell me one thing, Dr. Priyanka. What is
Yeah.
your finding in this patient? If I want you to do a MEC presentation, it's just make it fast. So I will give you, let's say, 1 minute, and
Okay.
just try.
Okay. Shall I start, doctor?
Okay, yeah, let's start.
Yeah. Dear examiner, I would like to present the mental state of my patient Sam, who has been brought by his wife while he was trying to hang with the rope. So he looked unkempt and not well groomed. I can't comment on his appearance as I couldn't see him. His behavior, I was not able to see his eye contact. He was cooperative though. Couldn't comment on body posture, and his speech is seemed to be in low, and volume is low as well. Um, his mood seems to be low, and affect observed is congruent to the mood. According to perception, he has active auditory hallucinations and delusion of guilt delusion of guilt. His thought form was linear. There was no loosening of associations of flights of ideas, and uh, his insight was intact. Cognition was present. Um, he lacked judgment, as he said, he wants to stay here. And he seems to be of high risk because he has attempted a suicide. He had a suicide attempt, and also he wants to die. And he's also a nurse who has access to medications. And he also has active auditory hallucinations. The reliability is unreliable because he wasn't able to give me straightforward answers. So I would like to take collateral history as well. The rapport was not well maintained.
Okay, very good. Thank you, Dr. Priyanka. So you covered almost everything. So for anyone who is doing role play today, just say on the appearance that you can just say that appearance is unavailable. Okay, that's fine. You can say in that way. But in your real exam, you'll be able to see the role player, and you can always comment on the appearance. So in this case, the positive findings that Dr. Priyanka said cover everything. So obviously, we will say in appearance, most of the time in depressed patient like this, you will get patient will be looking very gloomy. They will be well dressed, but they can be unkempt, and patient will not be maintaining eye contact, which is a very common finding in depression patient. So look for such thing. Sometimes they can also have a stooped posture, which you can find. Speech is usually slow and monotonous, and in the emotion, the patient usually says mood is low, and the affect that you will observe that will be congruent to the mood. Perception, this patient had auditory hallucination because he could hear the nurse's voice, but he could not see anyone. Now, this is a very important thing, as Dr. Priyanka has made sure of that. If you ask that, do you see, hear, or feel anyone, or feel anything that others don't? If I say, or your patient says, I can hear the nurse's voice, that they're talking about me, that I am a murderer, you have to make sure that is the patient able to see them? Like, is it a delusion of reference, or is it a auditory hallucination? Because these two can get quite confused in such case. How? That if the patient is actually going to the clinic or to the hospital, and then whenever he is walking beside the nurse, he is thinking that nurses are talking about him or people are talking about him. That will become a delusion of reference, not a hallucination. Whereas if the patient actually can't see the nurse, like this case, but can hear the voices, that becomes an auditory hallucination. So it's important to ask that, can you physically see the nurse, or you can't? Okay, so that's important to know about. So after perception, this patient thought form was linear. In terms of thought content, patient had a delusion of guilt, right? But patient did not have any other delusion. And then insight, cognition, judgment. Insight was poor because patient says, I don't need any medical help. cognition was intact, judgment was poor, this patient is obviously high risk because of active suicidal thought, active hallucination and delusion, lack of insight and judgment, and obviously patient is a nurse and she has access to drugs and others. The history is not reliable because patient having an active hallucination and psychotic feature with depression. So you have to take a collateral history from someone else. And rapport, I would say Dr. Priyanka was able to make a good rapport with the patient, but it depends on the exam. That if the patient is
Okay.
giving you answers, if the patient is being cooperative, you can say you are able to maintain a good rapport with the patient. Okay.
Okay.
All right. Thank you, Dr. Priyanka. It was good. Just keep an eye on the time.
Okay, doctor. Thank you.
Perfect. Thank you. Anyone having any questions on this case? Are you guys understanding how to take a history, how to actually do role play? Because the first thing you need to understand is how you're going to do role play with your study partner. Because role play is one of the vital part of your preparation for AMC clinical. And that's the main thing that we are going to show you today, that how you're doing role play. So that's important to understand. No question? Everything is good? Okay, who is next? Dr. Zahra?
Yes, sir.
Okay. How are you, Dr. Zahra?
Yeah, I'm good, doctor. How are you?
I'm good, thank you. All right, let me give you the case and we'll follow the same protocol, 1 minute reading time and then
Yeah.
7 minutes 30 seconds for the case.
Okay.
So this is your case, your time starts.
Okay. I think I can start.
Okay, all right, let me just say the time. Okay, so this is your patient. Your patient name is David. You can start.
Hello, David. This is Dr. Zehra, one of our doctor working here. So, as I can see that police brought you here. So, David, can you please tell me how are you feeling now?
I'm feeling perfect. I'm good.
Okay. So, can you tell me why police brought you here? What happened?
I don't know, doctor. I'm fine. I just don't know why police is bothered about me. I was just like wandering on the street.
Okay. Okay, David. So, first of all, I want to tell you that I will ask you some questions. So, but whatever we talk today will be remain confidential between you and me, unless it is harmful for you or any other person. Okay. So, can you please tell me about your mood nowadays? How are you? How's your mood nowadays?
I feel fine.
Fine. Okay. And what about the sleep and appetite? Like, are you able to eat or sleep well?
Yeah, it doesn't disturb me.
Okay, that's good. That's good to hear. Okay. And do you think that your life is worth living?
Yeah, obviously, because I am the messenger of God and God wants me to help everyone. So I have to live.
Okay, okay. So, do you think any thoughts of harming any other person?
No, why I would do that? I'm here to save the humanity.
Okay, okay. So, David, I will ask you some questions which seems strange to you, but these are screening questions, so that's why I'm asking to you. As you were saying that, so do you think that you are hearing something which others don't?
What do you mean? I know that God is talking to me and He's
Okay.
giving me advice how to do good on this earth.
Okay. And what command the God is giving you?
Just to help people.
Just to help people. Okay, that's good. And do you see God?
No, He's very busy. He has some other people like me, so He can't come.
Okay. And by any chance, do you think that people are spying on you, or they are talking about you?
No, they don't. But I know that they are very jealous of me because I have a special power and I can talk to God. They can't. So I understand that.
Okay. And do you think that your thoughts are being broadcasted on TV or radio?
No,
Anybody is inserting or withdrawing thoughts from your mind? Do you think?
no.
Okay. Do you know where you are right now?
In the hospital,
Okay. And who are you talking with?
doctor.
Okay. And David, if this room catches fire, then what will you do?
There is room. There is a fire in this room.
Yes. No, I'm just asking, just an assumption. What do you do if there is a fire in this room?
I don't need to do anything. Fire can't do anything to me. I have power.
Okay. Okay. Do you think do you think do you need any medical treatment?
No,
Okay. So, David, from the notes, I can see that you you are a patient. You are on antipsychotic. So, can you please tell me since when you are diagnosed with schizophrenia?
I don't know. Doctor. There was a doctor who advised me to take some medication. I didn't take that for long, and I'm doing really good now.
Okay. And when was the last time you met with the doctor?
Can't even remember. Maybe 2 years ago.
Okay. So, you're not taking any medication right now.
I don't need any medication. I'm fine.
Okay. Do you smoke or taking alcohol?
No.
Any other recreational drug?
Sometimes I take ice.
Okay. When was the last time did you take the ice?
3 days ago.
How much?
I even remember though because I was
Okay.
I was dry. Yeah.
Okay. Okay. Thank you so much, David. Now I would like to go to my examiner. Dear examiner, I want to present MSE of my patient, who is David, brought here by the police, and he is an schizophrenic patient and on antipsychotic, but he is not compliant. So I did. The parents of my patient is unavailable, and his mood is looking. His mood is all right, and what the effect I observed is congruent to his mood, and there is some auditory hallucinations but no tactile or visual hallucination, and he's also having the thought form is linear, and no flight of ideas or loosening of association, but there are some delusion of grandiosity because he thinks that he has some special power, and the insight is impaired, and judgment also impaired, but he cognition is intact. And I made a good rapport with the patient, but the history is not reliable, so I need to take a collateral history from the police, and he is moderate to high risk for suicide, so I need to admit him in the hospital. And then for the management, I would like to do some workup for organic, some baseline investigation like full blood count, ESR, CRP, urea, creatinine electrolytes, LFTs, toxicology screening for blood and urine. And I would like to do the CT scan of head as brain as well. And for the long term management, I would like to for the long-term management, I would like to refer my patient to the psychologist for cognitive behavioral therapy, and I would like to put him on put him on antipsychotic as well, because he is not non-compliant. So I would like to refer him with to the support worker who will help him with the medication. And I would like to arrange some family meeting for my patient, so that family knows better how is he dealing with the situation, and they can take care of him as well. Thank you so much.
Thank you. You still have 30 seconds. Very
Okay.
good.
I think I'm done.
Okay. Very good, doctor. So I'm very good with the approach, Dr. Jahara. So the main thing is that you are able to finish it in task. That's the very, very good. And even you still have 30 seconds. Okay. So that's really nice. What
Thank
I
you.
would say that your approach is very good. You are quite ready for the exam, but few things I would like you to add in these cases. First of all, let's talk about the history. So history, how you started, it was nice. You started with the confidentiality statement and everything. So that's fine. When it is a psychotic case, always try to ask all the delusion questions, because you never know what you have missed. Like, remember, like the RCGGP that we talked about. So delusion of reference, delusion of control, guilt, grandiosity, and also paranoid or persecutory delusion. So why I'm saying that, you got that part, like patient having a delusion of grandiosity. So that's fine. You don't need to ask the guilt, because it's psychotic patients. So guilt is usually a part of depressed patients. So that's not needed, which you haven't done anyway. The other thing that you didn't ask, that do you think people are talking about you on the street? Because that was positive in this case. I would give it to you. So that's a very important point that was missed. Then do you think anyone controlling you, or anyone trying to, you asked about anyone trying to harm you or is spying on you, and I said that no, but everyone is jealous of me. There is a delusion called delusion of jealousy, which also falls under delusion of persecution or persecutory delusion. So if you say in here that patient have delusion of, so in this case patient would have delusion of grandiosity, delusion of reference, and also delusion of jealousy or persecutory delusion. Okay, so this is very important in MSc presentation. They don't like you to miss any single point, because everyone knows how to present MSc. Everyone knows how to take a history. That's why examiners are very picky in these cases, that if you miss like a very important point, like in this case, delusion of reference is very important point. Delusion of persecution or jealousy is very important. They don't like these things to be missed. Okay, so
Okay.
that's why any kind of psychotic cases, ask all the delusion question, even ask about the thought control, thought withdrawal, thought broadcasting, because these are very commonly given, and there will be multiple findings in these cases. Okay,
Okay.
so that's one thing. Other than that, it's also important, because if you need to manage a patient, you need to know the diagnosis. So this case, if you need to give a diagnosis, you need to know the duration of symptoms. So is this patient having this problem for, let's say that, is it schizophrenic disorder or is it a schizophrenia? So we need to know that if it is a relapse of schizophrenia, because what can happen in here, patient already diagnosed with schizophrenia. So if it is already diagnosed and patient is not patient, and you can also ask that how long you are having these symptoms. If patient say, doctor, I'm just having these voices and all other things for the last 6 months, and patient previously 2 years ago was diagnosed with schizophrenia, so this 6-month thing will be a relapse of schizophrenia. Is this making sense?
Yep. Yep.
Yeah. Sometimes you also can get a schizophreniform disorder in the exam, in which case the duration of symptom will be less than 6 months. Okay, so we need to know always in these cases, especially if there is a diagnosis or a management in the task, we need to know that how long you're feeling this way. So that's the important thing that we would ask. Other than that, everything is fine. The history is pretty good. In terms of MSc presentation to the examiner, you covered everything that you asked for. So if I see you asked about emotion, yeah, everything is fine. The only thing that you missed those delusion thing, but other than that, it's okay. Risk assessment. We haven't discussed this risk assessment in our last class. So what, and if the task specify that you have to explain with the risk assessment, then you have to give a little bit more point in here. As you have time and you are very quick and it's quite understandable what you are saying, so you can usually, like, you can easily do all of this. So in the risk assessment, what you will say that this patient is high risk because of active hallucination and delusion, lack of insight and judgment, patient having lack of support because he is living on the street, and patient is also a substance abuser. So these are all risks for this patient. Substance abuser, lack of understanding of the condition, living on the street, so lack of social support, active hallucination, active delusion, no insight, no judgment. These are all the points that we usually will say in case of risk assessment. We will discuss that there is an important thing that we follow for risk assessment cases. We will discuss along the way in this class. In case of management to the examiner, so if we come here, any kind of management, we divide it into short term, which is the immediate management, and long term management. Now, again, if you are running out of time, then don't bother about it. If you are not running out of time, then you can always do this. I will discuss how to make it longer and how to make it shorter. If we have some time, we will say that for this is most likely a case of like a relapse of schizophrenia. So that's why I need to, because the patient is a high risk, I need to admit this patient in the hospital. If patient refuses, even after that, I would keep him admitted under Mental Health Act. Okay, so under Mental Health Act, we will be able to keep this patient in hospital for the patient and others' safety. And then what will happen? He will be assessed by an acute mental health team in the hospital, where a psychiatrist most likely is going to start him on antipsychotic medication. Psychologist will start cognitive behavioral therapy when he becomes a little bit more stable. And then he will be also, mental health nurse will assist him during the stay in hospital. So these are the three people who will actually be the part of this acute mental health team. So these are called acute mental health team. And also you will be doing a full organic workup, which will include full blood count, inflammatory marker, then kidney function, liver function, blood sugar, thyroid. But very important is the urine and drug screening. Sorry, urine and blood screening for any drugs. Now I have written in here CT scan of brain, but it's not always that we have to do a CT brain. For this case, we already know that what's going on. And it's not an elderly patient or something like that. That patient is confused. So we don't necessarily need to do a CT scan of brain just yet. So keep that CT scan brain like out of the picture for now. Do the blood test and the urine test for the drug, and then you will decide if this patient needs a brain CT or not. In terms of long-term management, once patient is stable on the medication, you will be able to send the patient back home. But back home, he needs someone's help. So you will need to arrange a social worker who can visit him and see how he is doing. You can also involve a community mental health worker or a community mental health nurse who can also help him during the like out of hospital environment. If patient having any drug issue, like in this case, patient is taking ice, you can also refer the patient to a drug and addiction rehab center. Okay, and then you will write a letter to the GP who can review the patient regularly. So that will be the long-term management. If you're running out of time, in this case, as part of the management, you will need to say that this is the diagnosis. I need to keep the patient in the hospital. I will do a full organic workup, including a urine and blood drug screening. And then I will involve the acute mental health team. Psychiatrist will most likely put him on antipsychotic. And then once he is stable, psychologist will give him behavioral therapy and the mental health nurse will assist him. And then once he is stable, we will discharge him to the discharge him back to community, but you will have social worker and community mental health nurse who will be working for him. So it will be very quick in that case. But if you have time, then you can always make it short term, long term in that way. Clear?
Yes, sir. Can I ask one question?
Yeah, sure.
So for the schizophrenia, we can't do CT scan or MRI of the brain because he is
No
having
need.
no need. Okay, thank you.
No, because he will not allow you to do it. If
Okay.
this patient first needs to be stable, because if you put him in the CT machine, he will just run. So
Yeah.
it will not be a safer approach to do it.
Okay.
All right, so very good, Dr. Jahara. I'm happy with how you have done it. Just do a little bit of polishing with these things, but you're good. Thank you. And some other questions from you guys. Can I take notes in the 2 minutes while I read the task? No, you can't. So the 2 minute outside is just for reading. You can't write. You can write in the 8-minute time. So when you start your preparation, when you start your task, in that 8-minute time, you can write anything you want. Can we access the recording to the class after joining the course? Yes, you can. Yeah, hearing voices is hallucination. But if a person saying there is a specific term that we use called delusion of reference. Delusion of reference is basically if a patient feels that everyone in the street is talking about him, or maybe in that first case we have done, nurses are talking about him, but physically he can see the nurses. That becomes a delusion of reference. But actually they are not. If you ask them, can you actually hear them saying that? Then they will say, well, I don't know, but I feel like they're talking about me. So that becomes a delusion of reference. But hearing voices only, but they can't see anyone, that becomes a hallucination. So what is the difference between schizoaffective disorder and relapse of schizophrenia? We actually talked about schizophrenia, relapse of schizophrenia, and schizophreniform disorder. So these three things, Dr. Hazem. So schizophrenia means that if a patient having hallucination, delusion, thought poverty, disorganized speech, if these things stays for at least 6 months, that becomes schizophrenia. Schizophrenia is not something which will be just continuous. It can be sometimes relapse and remitting kind of condition. So sometimes what can happen, even without medication, schizophrenia patient can become totally stable. And then suddenly the thoughts and everything can come again. So if that comes again, that becomes a relapse of schizophrenia, like the case that we have done just now. Then there is another condition called schizophreniform disorder, in which patient have all the symptoms of schizophrenia, but the duration of symptoms is less than 6 months and more than 1 month. So between 1 month to 6 months, the same condition, the diagnosis becomes schizophreniform disorder. All right, so that's that. Let's do a video case now. The video cases are coming a lot nowadays. We'll see how you do the video MSc cases. So who was next to do the role play? Dr. Afsan, right? Dr. Afsan, you can unmute yourself.
Hello, Dr. Arshan. How are you?
I'm good. How are you?
Good, thank you.
Good. So we haven't done this kind of cases before. So what will happen in the video case is that in exam, they are going to show you a video of interaction between a examiner and a patient.
Okay.
You'll need to hear them talking and then interpret your finding from their talking or conversation. It's a very easy case given that you don't need to take a history and extract all the information.
Yeah.
But the problem is that sometimes it can be very hard to get what they're talking because there will be no subtitle. So you'll need to listen carefully, find out what they're talking about, and then interpret. Okay.
Okay.
And then you just need to present that finding to the examiner.
Okay.
And you can get this in either face-to-face and as well as in online exam.
Okay.
Okay, so let's see this one. So for this, you don't need any time in the outside because you don't even know what's going to happen. So just give a read to the question, and then once
Okay.
you're ready, I will start the video.
Yeah. Okay. Yes, I'm ready, Dr. Ashan.
Okay.
Hello, Robert Smith.
Yeah.
Thank you for coming to see me today. I'm Dr. Stanley. I'm one of the doctors that works here. Obviously, anything that we say is confidential between us and the team that I work with, and your GP who's asked me to see you.
Okay.
I hear there've been some problems with your housing. Do you want to tell me a little bit about them?
Yeah, I've had all sorts of problems. I mean, where do you want me to start? My neighbours,
Mm-hmm.
police, people spying on me in my street. None of them will admit to it, but my neighbours, it's mainly them at number 9, but I've seen them talking to the ones at number 6 and across the road as well. You know,
So when did things start to go wrong?
I don't know. I mean, you'd have to ask them. Well, like when they started properly, like deciding that they wanted me out of the street. I think it was a few months ago. Months. It's been going on for months.
What makes you think they want you out the street?
Well, it's the harassment. It's the spying on me, putting bugs in my house, in my phone. You know, and that at first they thought I couldn't hear it, but now they know that I know that they're there. You know, saying things about me through the window. You know, talking about what I'm doing. I know they're doing it. You know, whenever I leave my front door, woman at number 7, she's always there. You know, she's clocking where I'm going and what I'm doing.
Why do you think they're doing that?
Well, I don't know. They just. I think they want me out.
Mm-hmm.
I think they're testing me, and they're trying to find out how far they can push me. Basically, it's all part of some test. I don't know why. I don't know what for. You know, you'd have to ask them. That's what I've said to the police time and time again. I've said to them, why are you asking me these questions? Why don't you just talk to them?
You said that your phone was clicking. What was that about?
A landline.
Your landline?
Yep. Somebody rings me or I ring somebody. Between 7 and 10 seconds in, I hear click, click, click. Click, click, click every time.
Any other explanation for that?
I don't know. Well, it could be, but you know, every single time, and then they're talking to me, and then they know what I've been saying down the phone. You know.
How are they talking? Where are they talking to you?
Well, I can hear them next door. Oh, he's on the phone again. Oh, he's reading that book again. You know, I can hear them saying it, and they know that I can hear them, and that's why they're doing it.
Okay, so just to summarise at this point, your phone's something's happening to your telephone. You can hear your neighbours talking about what
Yep.
you're doing, making a commentary on your actions
Every day.
every day, and you feel that there's some sort of reason for all their actions doing this. Any other things that you've got problems with?
Following me down the street. People following me when I'm going to the shop. You know, it's happening more and more. It's happening more and more. I mean, I've tried to explain to my friends about it. They get really agitated. They think I'm off my rocker, but they don't see it. You know, they're not living with it every day.
Okay.
You know.
So your friends are worried as well?
Yeah.
So
Well,
they've-
worried, or I mean, I don't think they're on it. I don't think, but they know a lot about what's been going. I don't know. Maybe the police have been talking to them or something, or maybe my neighbours have been talking to them. I don't know. Again, you'd have to ask them. But it's hard. It's hard to know. It's hard to know who to talk to, because they all,
So
they're all involved.
So this started happening a few months ago. Has it had any other effects on your life,
Well, yeah.
such as?
Can't really go out. Well, I can, but I know what's going to happen if I do. So I'm just trying to stay low key. I'm trying to stay out of people's way. I've hardly slept. I've hardly slept for the last, I don't know. I can't remember the last time I got more than 4 or 5 hours sleep.
So what disturbs your sleep?
I don't sleep until, I don't tend to go to sleep until after 2, 3. Well, I'm sure that they've turned everything off,
Right. Okay.
downstairs, and just can't, I'm worried about it.
Any problems watching the telly, listening to the radio?
Oh yeah. They're using the TV as well. They're using all. They've got all this technology, obviously. I mean, I know there's all these smartphones and whatever now. That all they need is one of them, and they can just. But yeah, TV. They've got the local news. If ever I watch that, there's always some little comment. There's always something they say in there at the end about what's been going on. Pretty much every time I turn the TV on now.
Okay.
I mean, it's it's all just the cable, isn't it? So they could, for all I know, they've just plugged it into that.
What do you mean the cable?
The cable TV, it runs down the street. Everybody's got access to it if they know what they're doing.
So obviously, this is all very distressing. All the different things that are happening. Can I take you back a little bit and just find out a bit more about you?
All right. So that's all about the video. Now you can present. So you'll get 2-minute time for the presentation. Your time just starts now.
Okay. I'm going to present a MSc examination of a patient named Robin, who is a middle-aged man. So he's a well-groomed person, and he's maintaining eye contact, and his posture is okay throughout the examination and throughout the history. His tone is normal, but sometimes in between he's speaking in loud tone, and the volume is also normal and taking no pauses in between. The emotion I can't comment on the emotion because he hasn't said anything about it. About the perception, I think that he's having the auditory hallucinations because he thinks that his neighbors are talking about him. And in the thought form, his thought form is linear. And the thought content, he's having the delusion of reference, as he thinks that someone is spying on him and his neighbors are spying on him. He's also having the delusion of persecution because he thinks that people are talking about behind his back. And regarding the perception, he's having the auditory hallucinations. I can't comment on the insight and the cognition and the judgment because it hasn't been assessed. Regarding the risk, he lies in medium to medium risk because he's having these delusions of reference, and he's having the delusion of persecution, and he's having the hallucinations, auditory hallucinations. And the doctor, she was able to maintain a good rapport with the patient.
All right. Very good. Thank you, doctor. So it was nice
you, doctor.
presentation, Dr. Afsan. So
Thank you, doctor.
anyone else wants to add anything with this, like any other finding that we should look for?
Did she comment on the speech, doctor?
Sorry, again, please.
Did the doctor comment on speech?
Yeah, he did.
Okay.
Yep, there was delusion of broadcast too. I observed
That's
that
right.
only. Yeah.
So there was the last one was thought broadcasting. Okay.
Yeah.
Thought insertion, I would not say thought insertion because that was not said in that way that they're putting thoughts in his head. But
Yeah.
thought broadcasting, we can say it. It's not still 100% thought broadcasting, but still we can comment on that. It should be fine if you can give a good reason. So
Yeah.
the other thing, Dr. Afsan, you mixed delusion of persecution with delusion of reference. So delusion of persecution is people spying on him, and delusion of reference is that the neighbors are talking about him, neighbors are commenting on everything that he is doing. These are the part of delusion of reference. Okay.
Yes, Dr. Shan. Yep.
All right. So in this case, you will say that, well, first of all, you'll give a good, let's say like we have got a patient. So dear examiner, I would like to, or I'm going to present a mental state examination of a patient who presents with some behavioral changes. So in terms of his appearance, he was well groomed, he was kempt and dressed appropriate to the weather, but he was kind of like restless, as you could see, and also he was sitting in a stooped posture. Okay, he was maintaining eye contact most of the time, and he was cooperative. In terms of his speech is normal, but sometimes the tone was a little bit high. But as a whole, there was no disorganized speech. There was no flight. There is no like rapid pressured speech. Those were absent. In terms of emotion, it was not assessed, so you can't comment on that. Perception, this patient had an auditory hallucination because every time first of all, he can hear the neighbors are talking about him. And also every time there is a phone call, at some point he hears click, click, click. So that's auditory hallucination. Thought form was linear. In terms of thought content, there was delusion of persecution, delusion of reference, and you can say thought broadcasting. Insight, cognition, and judgment was not assessed. The risk assessment, you can say it's a medium risk patient because of active hallucination and delusion. And obviously, doctor was able to maintain a good rapport with the patient. And this was not a reliable history, so the doctor needs to take a collateral history from either the neighbors or any other friends or relatives. Okay?
Yes. So, Dr. Shan, I have a question. If you can please answer.
Yeah.
So,
Yeah.
like the negative findings, do we need to explain them in a proper case too? Like if there's a case with where we have to take the history too, or just in this video, or like other cases where we have the time, then we can also say the negative findings.
Yeah. So ideally, I would say that if you have the time for MSc presentation, then try to give the negative finding also. But if you're running out of time, especially in the history cases, you might run out of time. In that case, just do the positive finding.
Okay.
Okay. But in the video case, you will get more time to present your MSc. So it's a good idea to say why you think that this patient has got delusion of persecution, this patient has got delusion of reference. So why do you think that? So that's also a good idea to add because you have time to present your MSc. Sometimes even they give you 3 to 4 minutes just to present MSc. So that's a long time.
Okay. Thank you, Dr. Shan.
Thank you. No worries. You're doing good. Keep it up.
Thank you. Yeah, just like I'm preparing for just a month. I'm basically a beginner, so yeah.
For a
It's so
beginner, you're
good.
doing really good, Dr. Afsan.
Thank you, Dr. Shan.
Thank you. Okay, so anyone else having any questions on this case? So let me just go through your questions. So Dr. Rand, do we have to cover all aspects of objective and subjective information included in the MSc for every case, or stick to the relevant concepts only? The main thing is that as long as you cover your aseptic J3R, that means the main information that you need to present the MSc, that's all that you need. You don't need everything, because if you are going for every information, then likely chance is you will run out of time. So it always depends on how fast you are And by being fast, it doesn't mean that no one will understand what you're talking. If you ask me what is the best speed, that will be Dr. Jahara's speed tonight. That speed will be a very good speed for the exam. So if you can have that speed when you are presenting your cases, you're being fast, but everyone can understand you. That's the important part. If you can be that fast, then it's very easy to finish task in the exam. Okay? But if you think that, well, I'm not that fast and I can miss things, in that case, I will say that just stick to the basic ones. That means for MSc presentation, you need mood question, you need suicidal risk question, you need hallucination, delusion, insight, cognition, judgment, cognition. These questions are must. If you can finish this, and then just every history should be wrapped up by asking heads, SADMA, and past mental health history. That's it. That's all that you need. Type of auditory hallucination is not needed. You don't need to say, is it a first person, second person hallucination? That's not needed for exam. There will be no timer giving in the exam. So there is no way you can know how much time you have left, Dr. Hafsa. That's the problem. And this timing part, you will actually understand when you do a lot of role play. With role play, your mind will know, your brain will know that I'm running out of time. So that's just an exercise which comes with a lot of practice. And Dr. Waruni, the insight and cognition was not assessed in this video case. So you will only say that it was not assessed. Never say something which was not asked in a video session. A lot of candidates, what they do is that they just make it up. In exam, it's very important to be honest. If you do a mistake, say it, but don't pretend that you haven't done the mistake, and don't add something which is not given. Like in the video session that we have just done, if Dr. Afsan would say that patient's emotion or patient mood was good, that would be a wrong thing, and they can fail you immediately. In such cases, it's better just to say that it was not assessed or I didn't hear it. As long as you say something like that, they're happy. All right, guys, so that's all good. Let's do a next case. Who wants to do the next case? Dr. Devendra, you can unmute yourself.
Hello. Hi, Dr. Ahsan.
Yes,
Can you hear
Dr. Devendra. Yes, I can hear you nice. Good. How are you, doctor?
I'm fine. How are you?
I'm good. Thank you. Okay, let me give you the case. Just a minute. I'll give you the case. Okay, so this is your case. Your 1 minute time just started. All right, so this is your patient. Your patient name is John. You can start.
Hi, Zone. My name is Devendra. I'm one of the doctors here in the ED. I can see that you have got wound in your leg. Can you tell me more about it?
So what's that? I don't understand you, doctor.
John, yeah, I can see that you have got wound in your leg.
Oh, there is a wound.
Yeah,
I
yeah.
didn't know that.
Okay. And do you know where you are at the moment, John?
Yeah, I think that police has brought me here in this
Mhm.
shithole. I just want to go. Yeah, I think it's a hospital, right?
Yeah.
Okay.
All right.
So why I'm here? I didn't do anything wrong. I was just doing my own job. So why I'm here, though?
Well, John, the police has brought you here to make your health better, so we can help you, okay? So I'm just going to ask you a few questions, and whatever we talk, it will just be between us, unless there's harm to you or harm to others. Is that okay?
Whatever. You can ask. I don't know. I just can't answer anything. I just feel like I need to sleep.
Yeah, I'm really sorry, John. I can see that you're very upset. I'm really sorry for that. Can you tell me how long have you been feeling like this? Like, how has your mood been like this?
I'm fine. I said that I'm fine. It's just the police who is, I think he has some grudge against me. That's why.
Okay. And do you know why the police brought you here today?
No, I was just roaming around the street. It's
Or
even I can't do that. I'm the citizen in this country, and why I can't walk on the street? Why the police is doing like this with me?
right. Okay. And John, can you tell me how your mood has been so far? Like, are you feeling all right, or is there days where you feel very low or very high?
No, I don't give a shit about these moods and everything.
Hmm.
Just let me go, doctor. You have more important patients. Just let me go.
Can I ask you a few other questions? So once I make my assessment, then we can have a chat about going home. Is that okay?
Yeah.
And can you tell me, have you been eating all right?
Yeah, I eat whatever I get on the street.
Okay. And you're sleeping okay?
Yeah, I'm homeless, doc. I sleep everywhere.
You sleep everywhere. And do you get enough sleep, or you feel like you're not sleeping enough?
I don't care. The devil is after me anyway, so he's going to kill me anyway. So who cares about sleeping and everything?
Okay. Can you tell me who David is?
That's a devil, not the David.
David.
I hope
Sorry.
it was David.
Okay, David. And why do you think that David is after you?
I don't know. It's just like the police. Everyone is after me. I can see.
Okay. And so you can see the devil, or can you hear him? What do you mean by that?
I can only hear him. He knows everything I'm thinking. I don't
Okay.
know how he does that, but he knows
Right.
everything. And wherever I am, he's saying some things to me that he's going to kill me.
And how long have you been hearing the devil for?
For the last few months.
Last few months? Okay. And can you see the devil as well, or is it just the voices that you have been hearing?
Just the voices.
Just the voices. Okay. And can you see anything else like others people don't see apart from devil? Anything else? Anything unusual?
No.
No. Okay. And just few other questions. Do you feel like your life is worth living?
Yeah, I want to live, but the devil is going to kill me anyway. I can't help myself, I know.
I'm
Uh,
really sorry,
I'm
Zon.
just drinking. I'm just drinking now so that I don't even understand what devil is doing to me.
Yeah, I'm really sorry, Zon. When people are hearing this kind of voices or going through tough times, sometimes they feel like hurting themselves. Have you ever been getting this kind of thoughts of hurting yourself?
No.
And have you got any thoughts of hurting others? Let's say if you find the devil, what would you do?
I wish I could get him, but I know I can't do anything to the devil. He's too powerful.
Okay, all right. And I'm just going to ask you a few other questions as well, if that is okay with you.
Yeah.
Do you think there might be like some other people that are spying or talking about you, anything like that, apart from the devil?
No.
Do you think the devil is trying to control you?
No.
Okay, and do you think the devil can hear your voices or maybe can put new thoughts into your mind?
But yeah, I know that he knows everything that I'm thinking.
Okay, all right. And do you think you need some medical help?
No one can help me, doc. It's the devil. There is no medication for it.
Okay. And Zon, let's just say, if there's a fire in this room, what would you do?
I would run.
Okay. And I can see that you told me you were in the streets. And how is your support? Like, have you got any family or anyone nearby?
No, everyone is scared about devil, so they left me.
Okay, so you're all by yourself?
Yeah.
I'm really sorry, Zon. And you told me you're in hospital. Can you tell me what is the day today?
I don't know, doc. I live on this street. Who knows about the day?
And do you know who I am?
Yeah, you're the doctor.
Okay. All right, Zon. I'm just going to ask you a few personal questions, if that is okay. So do you smoke cigarettes?
No, I don't have money for it.
Do you do any drugs?
No, I just drink alcohol, whatever I get in the bin.
Okay. And have you got any mental illness in the past? Have you got any medical issues, anything like that?
No, I'm perfect. I'm healthy. It's just the devil who is messing up with me.
Okay. And how has your health been in general, apart from the devil that's putting thoughts into your mind? Apart from that, how is your health in general?
Fine.
Okay. All right, John. Thank you for talking with me. If you would excuse me, I'll just like to talk with my examiner now. Is that okay, John?
Yeah.
All right. So, dear examiner, I'd like to present the mental state.
Time up.
Okay.
Okay. So the timing, it is very hard case. So, but that's fine, Dr. Devendra. You've been doing good. Let's give the MSc presentation. I'll give you 1 minute 30 seconds for it. So
Okay.
let's start.
All right, dear examiner, I'd like to present the mental state examination of John, who is a 47-year-old man who was brought by police with ulcer in his medial malleolus, was roaming around the street. On his appearance, I couldn't see him, so I can't comment much about it. His behavior, I couldn't see him as well, so I can't comment much about it. His speech seems to be normal, but occasionally his tone is low, and it's slow and monotonous as well. There's no rapid or pressured speech. His mood, according to the patient, his mood is unclear. So the effect, I can't comment much about it. His perception, so he has got auditory hallucination. He says that he is hearing devil and who is trying to hurt him as well. His thought form is linear. His thought content wise, he has some delusion of paranoia, of paranoid delusions. He doesn't have delusions of grandiosity or delusions of reference. His insight seems to be impaired, and his insight is intact. Cognition I would say, seems to be impaired. His judgment is intact. I was able to build good rapport with the patient. With the ongoing active auditory hallucinations, I can see that he's in moderate to high risk, and with the active wound in his leg as well, he has got high risk. And reliability wise, I suppose he's quite reliable, because I can still take some collateral history from the police, but he doesn't have family members, so I can't take much from them. So it will be the police. So yeah.
Okay. Thank you, Dr. Devendra. Very good. Okay. So, tell me one thing. So this question is for everyone. What is the one thing that Dr. Devendra has missed in the MSc presentation? Okay. No one still can't say. So thought withdrawal was missed. Remember one time I said that everything I think, devil knows about it. So that's thought withdrawal. It's a very tricky thing to get, but you have to be very, very careful when you're talking to a patient, especially for MSc presentations. You have to be very careful whatever they are saying. There is always some information there. So what I would suggest for everyone, whenever you go inside the room for 8 minutes, write aseptic J3R in this way. So if you have a paper in front of you, so you'll be just writing A, C, E, P like this, so that any finding you get, just very quickly write appearance unkempt, or speech high, emotion. If the patient say my mood is fine, just write fine, because you will forget about it at the end. Like Dr. Devendra has said that mood was not clear. Actually, when he asked about the mood, I said, I'm fine. That's my mood. So mood is always what patient says about their mood. So in terms of emotion, patient says his mood is fine, but the affect I have observed, it seems to be disturbed, because this patient's mood is not fine. He is disturbed in terms of his mental health. So you can always comment in that way in this case. The other thing I would say, this patient's judgment was good, because he said he will run away if there is a fire in the room, but the inside was intact. Okay? Sorry, judgment was intact, but inside was impaired. Why? Because when he says about, well, do you need any medical help? The role player said that I would, but there is no one who can help me, because there is no medication for the devil or something like that, right? So it means that patient doesn't want medical help, or patient actually doesn't have the insight that someone can help him. Okay, even though he says that I would, but still he says that there is no medication for the devil. So you can still give the reason that inside was not right in this case. And in an active psychotic patient, inside is very unlikely to be intact, because that's a part of your diagnosis. The other part, cognition, you can say the patient was oriented to place, because he knew that this is a hospital. Person, because he knew he is talking to a doctor, but not to the time, because he doesn't know what time it is or what day it is. Okay, so he was oriented to place and person, but not to the time. Okay, so that's that. This patient is moderate to high risk, because there are lots of things: active hallucination, delusion, lack of insight, patient having an ulcer on the leg, patient even doesn't know about it. Okay, and patient is substance abuser, which is the alcoholic. When there is a relevant assessment in the task, they're not just asking about taking a psychosocial history or taking a mental status examination. when there is relevant assessment, sometimes they also look for that if you ask a little bit more about the alcohol intake of this patient, because obviously patient was trying to show you that he's drunk. So you should ask a little bit more that, well, it seems like you might be drinking, or you can just ask that, do you drink alcohol? Patient would say, yes, doc. So you can ask a little bit more about the alcoholic history. When we will do the substance abuse cases in the class, you will know about how to take a proper history in terms of substance abuse disorders. But in this case, it is also important to ask a little bit about the alcohol intake and how much he is drinking, when was the last time he has drunk. So a lot of things we need to add in here in terms of alcohol. Okay, and apart from that, you can just finish with the past medical history, AIDS and SADMA very quickly. Okay.
Okay, thank you.
And
Thank you, doctor.
this case can appear in the exam in many ways. Sometimes the case can be like, they might ask you to take a history about the venous ulcer as well as a psychosocial history. So in that case, you will need to take history of the ulcer and do a little bit of management about that, which we will discuss later on in the class anyway. So sometimes it can be just psychosocial history. Sometimes it can be history of both ulcer as well as psychosocial history. That's right, Dr. Shafwa. Dr. Javeria, the suicidal question is not about judgment. It's a different question. Suicide is a risk assessment question. If patient wants to commit suicide, that's a risk assessment question. It doesn't fulfill the judgment question yet, because judgment is something like, what will you do if there is a snake in this room, or if there is a fire in this room? So this question is specific for judgment. If a patient wants to commit suicide, and if we say that patient doesn't have judgment, it doesn't look right. So I would rather ask two questions, judgment fire question as well as the suicidal risk question in the exam. In this case, do we need to do ulcer examination? Not really. What we need to do is that initially, at least you should say that, I'm very sorry to know that you have gotten wound on your leg or on your foot. Okay, the question will be much elaborated in the exam, so you will know where exactly is the ulcer, which foot it is. So you can always say, I'm very sorry to know that you have got a wound on your right leg. Is there any pain there? Do you want me to give you some painkiller? Patient will say, oh, I don't even know there is something there. Then you will say, I'm very sorry in that case, but what I'm going to do is that I'm going to ask my nurse to take care of this wound, and we will put a dressing over there. So at least say something like that you have managed that part. Okay? If you forget about it, if there is a management in the task, then at least you say it in the management. But it's a good idea to say that you're going to take care of it rather than just leaving it. Okay? So that's all about it. What if it's a video case? Now, the main thing, Dr. Javeria and everyone, you can say anything in the exam as long as you can give a proper reasoning behind it. If you can give a reason that, well, the judgment was not assessed in this case, but because my patient is suicidal, it seems like he doesn't have appropriate judgment. If you say in that way, then sometimes the examiner will be fine with that. But do we really need to do this much problem in the exam? No, you can easily say judgment was not assessed, and that there will be no negative marking for that. But if you want to say, you have to give reason why you think this patient has got lack of judgment. As long as you give a proper, appropriate reasoning behind your information, you are fine. Okay? Good. So, who wants to do the next role play? I think, was it Dr. Javeria who was there? Yeah. Okay, Dr. Javiria, you can unmute yourself. Okay, I have to unmute yourself. Just 1 second.
Hello, doctor.
Yes, Dr. Javiria, how are you?
I'm good.
Okay, just 1 second. So, Dr. KK, can you please repeat the last point? So, the last point is that I said, as long as you can give a proper reasoning behind your point. Let's say that Dr. Javiria asks that if in the video case, there is no talking about the judgment assessment. So, but there is a conversation where they have asked the patient that if the patient is suicidal or not. And patient is suicidal. Can we talk about it? Like, can we say patient judgment is impaired because patient is suicidal? So on that point, I say that, well, it is not needed. But if you want to say it, then you can always say as long as you give a proper reasoning behind it. Which means that if you say judgment was not assessed, but because the patient seems to be suicidal and wants to harm himself, it looks like, or it seems like he doesn't have appropriate judgment. So if you say in that way, it's fine, no problem. So Dr. Rubina, if the patient doesn't want to leave the fire room, does it mean he's suicidal? Yes, it means if he wants to stay, most of the time it will be suicidal. All right, so let's do another case. All right, so Dr. Javiria, this is your case. Your 1 minute time just started. All right, so this is your patient. Your patient name is Sam. You can start.
Okay. Hi, Sam. I'm Javeria, one of the doctors here in the GP clinic. How are you
Doc,
doing
you're
today?
here. So let me tell you one thing that I'm doing really good, Doc. Say what you're going to ask me. Let me just answer for you. I'm doing really good. I've been thinking about a lot these days that why the school counselor is just getting suddenly paranoid about me. I know that he's just jealous about my performance. There is no one in the university like me, Doc. That's why they're just asking me to come to you. So what I'm saying to you is that don't worry about me. Let me go, let me do my job, and I'll be fine. Because in the next few months, you will be seeing me on the television that I'm getting the Nobel Prize. Because there is a lot of things going on in my head right now. I've been feeling that there is some problem in the string theory that even Einstein could not get, which I can only explain now. So that's all that going on in my head right now. I've been thinking about also solar eclipse. There is a theory that I want to put forward, and that's also going to give me another Nobel Prize. So as you understand, Doc, there is no other university student like this. So that's why the counselor is just worried about me. They're just trying to frame me for something because they can't even gain this kind of knowledge from their experience. When I can get that, they think that, well, I'm just an insane person.
I understand. So, could you tell me more about how your sleep has been?
I don't need to sleep. Why I would sleep, doc? When there is a lot of information in my head. It just whenever I try to sleep, I feel like, well, there is something else coming up in my head, and I have to wake up, do my job.
And what do you think regarding, like, if there is a fire in this room, what would you do?
There is a fire in this room. I would run, doctor. I need to live because I want the Nobel Prize.
And do you know where you are?
Yeah, I think I'm in the hospital.
And what is the time?
I don't know, doctor. I've not been sleeping for the last 7 days. So I can't even know when is the day and night.
And do you know who I am?
Yeah, you're the doctor.
Okay. And do you think you can see or hear things that other people cannot?
No, doc. Do you also think like my school counselor that I'm a crazy person? I'm not crazy, doctor.
No,
It's
these are
just
just some
like
screening
because there's a
questions.
lot of information in my head.
These are just some screening questions. I don't mean that. So, uh, 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 you can't hear, see, or feel anything that other people cannot, right?
No, I'm not insane. I know what you're asking about.
All right. Okay. So, do you think people are talking about you behind your back?
I don't know, but everyone is talking about me because I am the best student that the university has seen in over a decade. So yes, everyone is jealous about me. They're talking about me all the time.
And do you think someone can control you, your thoughts?
No,
Do you feel guilty about anything?
no,
Do you think people can put thoughts in your head or take thoughts out of your head?
no. But I think they would do that, right? Because I have a lot of information.
And do you think people can hear what you are thinking, or it is being broadcasted in TV shows?
No, I would not let them to do that.
Okay.
This is my
And
information.
do you have any loss of concentration?
No, if you ask me, I have more concentration.
And any increased energy?
Yes, I feel very energetic.
And do you ever get thoughts in your mind? Whatever we discuss will remain between us. That someone like harming yourself or someone else?
No, doc, I would never do that.
Okay, that's good. And how's your appetite?
Yeah, it's fine. Not bad.
Okay. Uh, 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 Thank you so much. I'd now like to present the MSc of Sam, who's a 19-year-old university student. On appearance, he is well groomed and kempt and dressed appropriate to the weather. In terms of behavior, he is cooperative and maintaining eye contact. In terms of his speech, he uh, seems excited. However, his speech is normal in tone, volume, and rhythm. And there is little bit of that like pressured speech as well. However, in terms of emotion, he said that he has, in terms of mood, he said he has good mood, which is congruent to the effect I observed. In terms of perception, he has denied delusions of auditory and visual and tactile hallucinations. And his thought form is linear, and his thought content contains delusion of reference because he thinks people are talking about him, and delusions of persecution because he thinks people are jealous of him, and also delusion of grandiosity as he thinks that he can win 2 Nobel Prizes and he's smarter than Einstein. In his insight, he lacks insight because he thinks there's nothing wrong with him. His cognition is intact into to place and person, but but he does not know the time. His judgment is fine because, as he said, he will run out of the room if there is fire. His history cannot be relied upon because he's having active illusion. But I was able to build some rapport with him, and he's at high risk. He's at medium to high risk because he has active delusions.
All right, perfect. Thank you, Dr. Javier. So it was good, right? So you have been calm throughout. That's really important in these cases because most of the candidate will lose the calmness because it is very hard when a role player will talk and talk and talk. It becomes hard, and it's very, very common that you will go all over the place. That also happened initially with you. You started with judgment question, which is really not like the first question which we would ask in such a case. So that's fine. You can get lost, but as long as you come back, you're fine, which you did later on. So you asked all the important questions. Now, very, very important is to give the confidentiality initially. If you do it in the middle or at end, doesn't matter. Okay, so confidentiality has to be given initially. The first time when you have talked, you should have given the confidentiality, and then start asking questions as you go. So better to start with the mood, sleep, appetite, suicidal questions, then going to the hallucination, delusion. It's not like that we always have to follow it. If something comes up, like as in this case, if we see that patient is showing features of mania, we can always ask questions related to that. So as you also asked that, how's your appetite? How about your sleep? These patients will have like lack of sleeplessness. There will be increased energy. So very concentrated sometimes. Their attention will be all over the place because they will be thinking about too many activities at this time. If you ask the patient that, are you spending a lot these days? And ask about, very important in many patients is to ask about their recreational drugs because they will be drinking heavily, taking lots of recreational drugs. They will have a reckless driving history, spending a lot, and you might also get that this patient is having like unusual sexual practice. Like if you ask that, well, are you getting involved with spending a lot of money, such as gambling? And how about your sexual life? So you'll find all the positive findings in these cases anyway. But do we really need to go in that much detail? No, because your task is present MSc to the examiner. As long as you cover the aseptic J3R, you will be fine. But there are cases which is where you have to give the diagnosis to the examiner with differential diagnosis. In that case, yes, you will have to ask those questions. Okay. Now, what else you have missed in here? Let's talk about MSc presentation. So appearance we can't talk about here. In case of speech, this patient had a lot of loud, it was talkative. So patient was loud and talkative. There was rapid pressured speech, and sometimes there was normal tone. And then in case of emotion, I can't even remember if you have asked directly about the mood question or not. But if you haven't asked, then it's very important to ask about how is your mood these days. Patient would usually say in this case, I feel fantastic, I feel amazing, I feel really good. So because they're feeling euphoria in these cases, so you can always talk about that. And emotion also, the affect that you will observe will be congruent with the patient's mood. In terms of perception, patient did not have any hallucination. thought form was mostly linear, but there was a little bit of flight of ideas because patient was talking about solar eclipse, string theory, Nobel Prize. So there was a little bit of flight of ideas, but most of the time you could actually like understand whatever he's saying. Then in terms of thought content, very good. You commented on delusion of reference, delusion of grandiosity, and delusion of jealousy. And after that, the insight, cognition, was not insight and judgment was poor. Cognition, you said it right. The patient was high risk patient or moderate to high risk patient, given that patient has active hallucination, delusion, and lack of insight, judgment. You need to take a collateral history from the school counselor because she should know about this student, and you were able to maintain a good rapport with the patient. Okay, so good case. I'm happy with how you were maintaining the calmness during the history. That's very important because a lot of candidates, they just get puzzled when the role player talks this much. So as long as you are calm, you let the patient to talk. At one point, patient needs to stop, and that's the time you start. Okay?
Thank you, doctor, for the feedback.
Thank you. All right, so let's see if you guys have any question. And yes, this patient would have rapid pressure speech, flight of ideas, as we discussed. No, Dr. Hafsa, so good question. So can we ask that if your thought is inserted or withdrawn? We can ask. So you can directly ask, as you are giving that statement, that I'm going to ask you some strange and sensitive questions, but please be aware that these are screening questions that I ask to everyone. If you say that line, they will not be bothered. But if you don't say that line and you ask this directly, they can always feel just. As I was just when doctor asked me that, do you see hear things? I immediately said, do you think I'm crazy? Okay, so if you give that line, then the role player will not be bothered. Deletion of reference means that if a patient thinks that everyone is talking about him, that's deletion of reference. Should I cut the patient talking? Never. Allow the patient to talk in the exam. You never cut the patient talking. If you do that, you fail immediately. So you always wait for the moment when you can start. Patient needs to take breath, right? The role player cannot talk for 5 minutes. So there will be a time when he has to stop. At that time, you start. Okay? Very good. Well done, everyone. So we will finish with another video case today. And who wants to do that video case? I can't even remember who actually was said that you want to do. Is it Dr. Saima? Okay, Dr. Hazim. Dr. Saima, yeah, okay, you can come. I'm not sure if Dr. Hazim or Dr. Saima, who was at first. And if patient takes long time in talking, should we listen the patient patiently? We should. Patient will not talk that much. Okay? Whenever patient stops a little bit, you go in. But don't just say like patient is talking and you can't cut him in between. It's very rude. Saima was first. Very good. Thank you, Dr. Hazim. Just Dr. Saima, I will just unmute you. Hi, Dr. Saima. How are you?
I'm good. How are you?
Good. Thank you. Okay, let me give you the case. So this is a MSc presentation as well, but it is a video presentation. So Dr. Saima is the same one like that we have done. So give a read and then we will start the video. Did you give a read?
Yes.
Okay. Let's start.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay, that must be very difficult for you.
Okay.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out that this is what was happening?
I came home one time and they'd moved the TV to the other side of the room, and
Right.
I knew then
And what was it that you knew at that moment?
that that they were for MI5.
Right. Okay. Okay. So it's been going on a couple of months.
Yeah, this new lecturer started at uni,
Right.
and he works for MI5. And
Right.
he basically drafted my housemates in, turned them
Okay.
against me.
Okay. Okay. Now I've noticed a couple of times while we've been talking that you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Well, I can hear them talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And do they sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right.
And
So what they're not when they're not in the house with you?
yeah, it's like they're in the other room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something,
Mhm.
they'll comment on that, like he's
Right.
left the house now. Or,
Okay. Okay.
you know.
Anything else? Do they ever talk to each other, perhaps about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them now,
Right.
and they're saying like I'm making trouble,
Okay.
and that they're gonna sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah, I do think things that aren't me. Like
Okay.
they're putting stuff in my brain. It's not me. I'm not thinking.
So different
that.
thoughts in your brain.
Yeah, that's
Right.
like it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch any of that crap.
Right. So it's not your kind of
It's
thing
not-
normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening, or
It's
who's
this-
responsible?
It's MI5. It's this chip they've put in my head,
Right. Okay.
and I can feel it all the
Okay.
time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No, no.
Nothing like that.
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No, if anything, there's too much in there. I wish I could unplug it.
Okay, okay.
Just get this thing out of my head.
Right. And you mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they
Right.
know where I am at all times, and I can feel it moving around, like rotating
So you can
around.
feel the physical sensation in your brain. Okay, okay. That must be very difficult for you.
I don't know why they're doing this to me. I've done nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
No, I feel fine. I'm not ill or anything. I just want this thing out of my head.
Okay. I mean, it sounds like a very difficult time for you. Can I ask you, Andy, how are you coping with all this? How's it affecting you?
Well, I'm not really leaving my room much, and I sort of have to wait till they go out to go down and get some food. But they've been doing stuff to my food now, so
okay. Well, what do you think's happening to your food?
they're poisoning it.
Right. Okay. Are you actually eating much at the moment?
No.
Okay. Now, with all this happening.
All right. So that's it. So now you'll get 2-minute time to present the AMSc. Your time just started.
Dear examiner, I'm going to present the mental state examination of my patient, 19-year-old college student who presented with some changes in behavior. Regarding the appearance and behavior, he was well dressed according to the weather, well groomed, cooperative, was making eye contact time to time, but he was reacting to some unseen stimuli throughout the conversation. His speech was normal in rate and volume. It was not pressured speech or disorganized. Regarding emotion, mood was not assessed, but the effect I observed seemed to be a little anxious. And he has auditory hallucination, as he thinks that as he can hear her, and he has also tactile hallucination, as he thinks that there's a chip in his head. His thought form was linear. There was no loosening of association or flight of ideas. Regarding delusion, he has delusion of reference, as he thinks that everybody is talking about him, and he has delusion of thought insertion, as he thinks that someone is inserting thoughts in his minds. And he has delusion of persecution, as he thinks that everybody is trying to harm him. His cognition, insight, and judgment was not assessed, so I can't comment on them. Regarding to me, he was a high-risk patient, as he has active.
Time up, but you can continue.
He has active hallucination and delusion, and the doctor was able to make good rapport with him, and it was not a reliable history, so I would like to take a colorectal history from any family member. Thank you.
Very good. Very good, Dr. Simon. So you covered everything. That's the main part, right? So just I can feel the nervousness, because it must be that you might be starting the preparation. Yeah. Okay. For your first time, you have done very good. Okay. So, and you covered everything that was positive in here. That's the main part, because a lot of candidates miss tactile hallucination in here. You even did not forget about the delusion of persecution, which was given at the end, because the last point was they're trying to poison my food. That was the main cause why we think that this patient has got delusion of persecution. So everything is right. So you talked about thought insertion. It's a good idea that if something is specifically assessed, say that point. Like in this case, it was assessed if the patient has thought insertion, thought withdrawal, and thought block. Remember the last one that say that at any time do you feel that there is no thought available in your brain? That's thought block. So you talked about thought insertion. Just say that there was no thought withdrawal or thought block. Okay, so if some negative findings is there, it's a good idea just to bring them as well. Otherwise, you said everything. This patient had like auditory hallucination, tactile hallucination. This patient has delusion of reference, thought insertion, and delusion of persecution. And obviously, they haven't assessed the mood, they haven't assessed the insight, cognition, or judgment. High risk patient, rapport was well built, but it is not reliable. So patient, we need to take a collateral history anyway. All right, very good, Dr. Saima, keep it up.
Thank you, doctor.
So do you guys have any questions regarding the role play session that we have done today? So this is all about MEC role play. Time to time, we might do another psychiatry role play in the course, but this is not the end of psychiatry. We just did a part of psychiatry today. But there will be more psychiatry classes in the course, and there is another 3 or 4 classes anyway. So we'll be doing more and more role play on psychiatry, more and more cases as well. Okay. For online exam, is there a timer in between that tells us to move to the next task? There is not a timer, but the invigilator, sometimes they can give you a prompt that moves to your next task. So there is no timer given, but invigilator sometimes can give a prompt timing to you. Can we write on paper during online exam? Yes, in the 8-minute inside, when you're doing your task, you can write on a paper. Yeah, delusion of persecution and delusion of paranoia is same. Where was the part of tactile hallucination? Remember when the patient said that I can physically feel the sensation of the chip in my brain? That's the tactile hallucination. Tactile means some strange sensation and feeling. How many psych cases in the exam? Ideally 2. Sometimes we have seen 3, but 2 is the usual number of psychiatric cases. Very good, Dr. Ethan. So there might be cases where patients try to run away from you. The case which usually happens like this is the mania case. So in mania case, sometimes patient becomes so hyperactive that they start to run away. But they will never run away from your room. It happens more in face-to-face rather than online. But most of you are going for an online exam anyway. So we don't need to like think about it too much. But if the patient starts to run away, ideally in face-to-face, if a patient stands up, you also stand up with the patient and try to calm the patient down. So you can always say something nice and good that, John, I understand that you are feeling this way and I will not waste any of your time. Would you please sit down with me for 5 more minutes and we will do an assessment and then you can go. There should not be any problem with that. Okay, so say very nicely and with gentle talking, you should be able to calm the patient down. Never say the patient that, John, calm down, sit down. Don't order the patient. How you handle the patient, there is a mark for that, especially for those cases. Be calm, be gentle and polite with the patient. Don't order. Always use the term please, thank you as much as you can. So can you tell about thought form variation? Dr. Sindhu, we discussed about thought form in the last class in detail. What I would say is to go through that class for a better understanding, because thought form has a little bit more discussion, how to find out about the flight of ideas, loosening of association. We have discussed with example in that class. So please go through that class. No physical exam in online exam. There will be physical exam in online exam. We will discuss about that in the course. Thought block. Thought block is a feeling when a patient thinks that there is no thought available. There is no thinking. So that's thought block. How many gynae ops cases? Gynae ops, one gynae and one ops case. That's the usual number of cases. Yes, Dr. Javiria. So usually theory classes, we allow everyone to participate. If you are an active candidate, you can participate in a lot of role plays with me and also with Dr. Cynthia. More chance with Dr. Cynthia because she will be doing role play sessions every week. And it is a role play session, so you will be doing a lot of role play. And also, once I finish the theory classes, I will also do some role play just like today. So there will be enough opportunity because half of our students do it offline, which means that they don't come online sessions. They just do it by themselves because either the time doesn't match or they are working doctors. They might not even come to the live sessions. They try to finish in their own pace. So almost half of our doctors are like that. So you will have an ample opportunity to participate in role play if you are active. Okay. No, the putting chip in the brain. So that's why the interviewer actually asks, do you physically feel the sensation of it? When there is a physical sensation, that's not a delusion of control. That's a feeling. That strange feeling is a tactile hallucination. Okay. And the patient would say that, no, I think the MI5 is controlling my thoughts. That will become a delusion of control. Okay. All right. So what I'm going to do is to discuss a little bit about the course that has started from today. Many of you are already enrolled. Many of you are doing just the free 2-week sessions. You might have some questions in your head that what we are doing in the course, how we are organizing the course and everything. So let me discuss a little bit about the course. And then if you have any questions, feel free to ask me again. So I will go into our website, and you can also go into the website and go through the detail about the course. So this is the website, and if you go to firstaidamc.com and then come in here, so let me show you how you can easily come over here. If you write firstaidamc.com, you'll come into our website, and if you go down, you should be able to get the 5 months clinical course. And in here, excuse me, in here we always put the updated details and everything. So the course is starting from tonight, which is 7th of October. It is a 5 months course. We took a trial class. If you have missed that class, which is our MSc theory session, the recording is here in the YouTube. You can also listen to it. 2 weeks free session is starting from. We will use the same Zoom ID. If there is any change in Zoom ID, we will obviously post it in the Facebook group. The 2 weeks free sessions will be on 8:30 p.m. in Sydney time. Now, only 2 classes, which will be taken by Dr. Cynthia because of some changes in her timeline. She was going to take it at 8 p.m. So your 9th October and 16th October, these 2 classes will be 8 p.m. and other classes with me will be 8:30 p.m. But in your actual course, this will be ideally 8:30 p.m. Now, so First Aid AMC Clinical, it is not a new course. We have been running the course over 7 or 8 years now. And there should be about 800 to 1,000 students who has passed from this course. And many of them are working in Australia as a doctor. many of them even pursuing the specialist career. So it's not a new course. We have changed over the time. We have updated ourselves as the AMC has updated the exam in every possible way. So the course will include full theory based on cluster-wise approach. You will get an idea about our cluster-wise approach, which is very famous. The reason behind it is that the cluster approach makes the preparation very concise, but it has a lot of information which you can use to do, let's say that with one history format, you can do 6 cases and that's done. You don't need history format for 6 cases. You just need to know the management. So when we start our cardiology in next class, you will see how we use our cluster-wise approach. It's very good. Role play of recent and most important cases. So once we do a theory session, we do a role play on that cluster. Like we have done MSc theory, we have done MSc role play. Again, when we do the cardiology theory, we will do a cardiology role play. So that's usually cluster-based role play that we would do. But there will be also one role play sessions every week, which will be taken by Dr. Cynthia, where you will get all the recent sample question role play with her. And as I say that this is not a new course. We have been doing these role play sessions for years and years. So in your portal, when you join the course, you'll be getting cases discussion starting from back in 2018. But you don't need that. But again, if you have time, you can always go back and see what were the cases. So we update the sample cases every month as the important cases are there. And we always make sure that you get an idea about the cases. If there is a new topic which is favorable for the exam, we try to discuss that topic so that you are well aware of that particular topic. Okay, so we'll be trying to mainly focus on 2023 and 2024 cases in your course. And also you will be getting all the class recordings of 2021, 2022, and everything that we have done over the last 3 to 4 years. So those previous batch recordings will be available in your portal once you start the course as well. So there's a huge collection of cases. If you do those cases, there is no way any new case can come in any exam because we cover everything. Okay, so video of all our role play sessions will be there. If any of you are going for exam, let's say in November, you don't have 5 months in your time. What will you do? You can still join the course because we give recordings of just the recent batch that we have finished, which is pretty much recent. And you can finish those recorded classes and even finish your preparation in 1 to 2 months. It's not only that if you're going for November exam or October exam, it's for everyone. Everyone who join our course, if you pay the full payment initially, you will start to get all our recorded classes from the past. Okay, this is a huge collection and huge opportunity because if, let's say we are taking 3 classes in a week and you still have 4 days left, and if you have finished our classes and you still have time, you can go through that recorded sessions and find out about those cases as well. And that's a very good way of preparing. Physical examination, we have a very, very good updated format of physical examination. We will mainly focus on online physical exam for your course because most of you will going for online exam, and also a little bit about face-to-face format because by any chance AMC starts face-to-face exam again, then you should know how to do it. We take online mini mock exam every 4 to 6 weeks. Obviously, you will get idea about communication and patient-oriented approach. You get a recording of every classes. So if we take a class today, you will get a recording in your portal, ideally within 24 to 48 hours. And that recording also you will get a prolonged access even after the course is finished. The notes in the software will be there until you pass your exam. We also discuss about job hunting, career pathways, registration and everything. And obviously we give you course completion certificate if you are a member of any of the RACGP or ACRAM, you can also add our classes and get some CPD. The cost is $8.99 Australian dollar. If you join now, you will be able to pay it with 2 installations. But anyone joining off in the middle, then they need to pay full. Classes are usually 3 days a week. Saturday, Sunday, and Wednesday is usual time. And yeah, that's it. So as I said that First Aid AMC Clinical has the highest passing rate for clinical exam, even though sometimes we see that 1 or 2 students passing a particular date in AMC clinical exam, and that student is ours most of the time. So we make sure that you are well prepared before you are going for the exam. Okay, so if you follow our guideline, if you do the hard work, I would say that you should be able to pass the exam. Okay. Any other question? And Dr. Ethan, can I write down aseptic J3 here? Yes, you can write down. Yeah, mini mock exam is different from the regular role plays. And doing role play, Dr. Javiria, is how we have done. The main thing is that when you have 2 or 3 study partner, fix a time that, well, maybe from 7 to 9 p.m. we'll be doing role play. So set a specific question or maybe a specific class, and both of you will do those cages, and then you will just do role play. Okay, that's how you should start doing it, and that's a very important part. So you should have a role play partner. That's must for this exam preparation. And how can we access the notes? So if Dr. Jamshina, once you are a part of the course, we will ask you to make an account in our portal, then you should be able to access the notes. All right, so that's it for tonight, guys. I hope you are enjoying the session so far. If there is any questions, feel free to ask me again in the next class. Next class will be with Dr. Cynthia. She will be doing some role play sessions with you. Now you will get an idea that how the role play sessions look like. There will be no specific format for that classes. It is mainly about giving random cases in front of you and finding out how you are doing that case. It is hard, but it makes you prepared for the exam, because in exam there is no syllabus. There is no specific format. You get questions from everywhere. So these are the classes which will prepare you for a random questions, looks like an exam. Okay. And for the payment, you can contact us through the email. So remember, I have shown you this one. So if you go here, you can see that we have our email ID here. So you can send an email in here, or you can also inbox me. So most of you should be in the First Aid AMC clinical group. So just send a message to me in the name of Arshan Ahmed, and then we should be able to help you in that regard. And I would advise, if you are planning to join the course, please don't wait for the 2 weeks free sessions to finish. The reason is that it takes time. It takes time for you to make an account in the portal, for us to also approve that it takes time. So if you are planning to start preparing with us, then do it from right now. If you're liking the course, I always say that someone can take a very good class, maybe 1 or 2, but someone cannot take 2 weeks free sessions and every classes you will like it. If you like every classes, it means it's good. Okay. So if you think that this is the right course for you, and you're feeling the vibe that yes, this is going to be the right thing for me, start preparing. Don't waste any more time. Okay. It is a long preparation. It takes time, and it takes a lot of patience and hard work. But if you do that, you can pass this exam. This is not impossible. As you can see, a lot of students pass this exam. Okay. Yes, you can pay via portal as well. If you put on subscription, yes, you can pay by portal. It's fine. And if you pay by the portal, then please make sure you send us an email that yes, doctor, I have made the payment. Okay. All right. So let's finish it here tonight then. Thank you, everyone. See you next class. Bye.